disease, a mother who doesn't, and you know, one of their children, and actually we say that each child has a 50% chance of developing the disease or having the mutation. So that's a prototypical pure genetic disorder. Now, the HD gene itself was actually sequenced in 1993. And so that was, what, 28 years ago now, after a 10-year effort. So we were all excited when it was sequenced. This is 1993, but it's actually been 28 years. We've done a lot, but maybe not as much as we had hoped. So the gene itself is located on the short arm of chromosome 4. We know that. We know that it's autosomal dominant and essentially fully penetrant, which means that if you have the mutation, you're likely to show it during your lifetime. And we see that here. If you have at least 40 CAG repeats, it's going to be fully penetrant, which means that you will be affected during your lifetime. And that's presuming you live long enough. If you die in a motor vehicle accident in your 20s, you're obviously not going to show it. And then the risk to your offspring, again, 50%. Each child has a 50% chance of developing the disease. If you have less than 26 CAG repeats, you're by definition normal. You will not be affected during your lifetime, and there's actually no risk to your offspring. So if you're normal, you don't have the mutation, there's no way you can give it to your children. Probably the more interesting situation is kind of in between. We say that if you have 36 to 39 CAG repeats, that this is called reduced penetrance. You may or may not be affected during your lifetime. And again, your offspring will have 50% risk. And this is sort of probably one of the common situations when people have a mutation and they say, well, none of my parents had the mutation. Looking back, nobody had it. Where did it come from? It wasn't in my family before. Most likely the parent had something like 36 to 39 CAG repeats, which gave them a reduced penetrance. So they may or may not have shown disease in life, but the children still had a 50% risk. The intermediate alleles, these are the 27 to 35. People are classified as an intermediate allele, and they are usually not affected during life at all. There is an elevated risk to offspring, but it probably is less than 50%. HD can exhibit anticipation, and this is primarily when it's the father who has the mutation and gives it to his children. What anticipation means is that most likely children will have a higher number of CAG repeats and possibly show the disease at an earlier age than the parent. So when the father is the person who has the mutation as opposed to the mother, we tend to see an increase in the number of CAG repeats in the next generation. So HD is caused by a mutation in the HTT gene that results in progressive depletion or loss of nerve cells or neurons. And what you see is the normal situation where there's no HTT mutation right here in this top bar. And it's important to realize that Huntington protein is actually a normal protein and we need it. And we'll talk about how the Roche trial probably showed us how important it actually is, we think. So we think that normal HTT or normal Huntington, or what we call wild type Huntington, is actually important for reasons we don't exactly know, but somehow keeps the cells in the brain and in the central nervous system working well. And that in the HTT mutation situation, the actual DNA is affected. As we know, there's a mutant Huntington area. This mutant area then becomes transcribed into mutant Huntington messenger RNA, which then becomes translated into the mutant Huntington protein. And we think that it's that mutant Huntington protein that causes cellular dysfunction and then neuron loss or nerve cell loss and leads to Huntington symptoms. But it's important to remember that in the normal situation, where there is no HTT mutation, the wild type Huntington DNA, it's transcribed it into Huntington messenger RNA. It's translated into wild type Huntington protein, and that wild type Huntington protein is required for normal cellular function. So unfortunately, most of the Huntington lowering therapies that we have right now are indiscriminate. They can't discriminate between mutant and wild type. And so what they do is just lower all of Huntington. And that's important to remember because yes, we're definitely lowering the mutant Huntington, but we're also lowering the normal Huntington. And that's probably causing a problem. Okay. So we're going backwards. Let's not do that. Let's go forward. Okay. So we think that producing mutant Huntington in the brain leads to neuronal dysfunction and death. And what you see here is a cartoon really of a nerve cell. This is the cell body. This is its axon terminals. And what we see are clumps of mutant Huntington in that cell body. And we think that those clumps of mutant Huntington are what causes the nerve cell body to clog up and not function well, that ultimately leads to it's the death of that nerve cell. And you can actually see here in some old electron micrographs and histology micrographs and also electron micrographs from 1997 and even this more recent one from Saul Snyder, you can actually see actual clumping of Huntington in the neurons, some clumping right here. And this is right inside the nucleus. We see clumping of the Huntington protein. So unfortunately, what ends up happening is widespread degeneration in the brain. And years ago, not too many years ago, we used to think that it was only the caudate nucleus, which you can see right here. We're only seeing a half of the brain. We're looking at the brain from the side, but we're looking at it from the inside, if you will, to one side of the brain, in this case, the right side of the brain. And this right here represents the caudate nucleus. And this is actually the body and tail of that caudate nucleus. And what you can see is it's sort of all outlined quite nicely in gray. We used to think that it was only the caudate and maybe the putamen that were affected by Huntington's disease, but we know now that a lot of the frontal cortex, for example, this whole area, it also atrophies or shrinks, even in the earliest stages of Huntington's disease. So we talk about frontostriatal dysfunction because we lose areas of the frontal cortex and also areas of the striatum, which is the basal ganglia that includes the caudate and the putamen and the globus pallidus. And what you see here is actually that progressive brain atrophy in Huntington's disease. These slices of the brain are a little bit different than what we looked at before. These are what we call coronal sections, so we're going front to back. And you can see this is almost normal. We see some of that gray matter right there. We see some of that subcortical white matter right here. 5 years later, we're seeing a little larger ventricle, if you will, a little bit less gray matter. And by 10 years later, we're seeing much larger ventricles here and here because some of the tissue of the basal ganglia has gone away or shrunk or disappeared. Now, the natural clinical course of Huntington's disease really varies a lot. And we often say that the typical age of symptom onset is 30s to 50s with a mean of about 45 years. And just yesterday in clinic, we saw someone who was actually much older. They were in their 60s. And the first doctor who had seen them and then learned of the diagnosis of Huntington's disease afterward said, "Oh, I didn't think you could have Huntington's disease because you're too old." Oh, sorry, I need to go back. Yeah, sorry, thank you. So I didn't think you could have it because you're too old. So it's important to remember that's just the typical age. It's like a bell-shaped curve. So the majority of cases will have symptom onset from 30 to 50, but we see onset really in the teens and 20s and 30s. We see onset in the 60s and 70s and even 80s. So we've diagnosed people in their 80s. So important to realize that even though the typical age of symptom onset might be 30 to 50, that you can really see disease onset anywhere from teens really to 80 years old. And the point that's being made here is this is actually data from Jim Gazella that was published in 2014, is that there's actually a loose correlation between CAG repeat length and the onset and the rate of disease progression. So what he's showing here is age at onset on the y-axis. So age at onset goes really from 1 year all the way to 100 years right here, although we don't have anyone that's that high. We see someone in their 90s. And then along this x-axis, we see the number of CAG repeats. I guess if I hit this at all, it disappears. Okay, sorry, there we go. Okay, and so what you can see, I think, very clearly by looking out here at the highest number of CAG repeats, there you have 55 CAG repeats. Well, your onset in those cases is teenager, okay? It's pretty much from about 16 or 17 to about 30 something, okay? And the mean would be probably in the early 20s. So when there are a very high number of CAG repeats, something like 55, you're actually going to see very early onset. On the other hand, when you come over to this side and you have 40 CAG repeats, you see that the onset is much later, okay? And so most of the onset is from about 40 to 80. Now it's important to realize that. So you can have 40 CAG repeats, and sometimes people will say, well, if I have 40 CAG repeats, what's my age at onset going to be? And we can't really tell. Why? We know it's going to be later. We know it's not going to be teenage pretty much, but look at this. You've got onset here with 40 CAG repeats, even in Jim Gazella's data, from late 30s to early 80s. So that's 4 to 5 decades worth of onset, if you think about it. So it's very difficult to precisely say when someone is going to develop disease or start to show symptoms just by the number of CAG repeats. And what that tells us is that there are other genes and other clinical characteristics that can modify the age at onset. So we think that different things like depression or alcohol use or cigarette smoking or any number of things, and then of course other genes themselves can actually modify by 20-25 years sometimes the age at motor onset. So important to realize that there is no doubt a loose correlation between CAG repeat length and symptom onset, and it's negative in the sense that the higher the number of CAG repeats, the lower the age at onset. Conversely, the lower the number of CAG repeats, the higher the age at onset. But it's a very general or very broad statement. We also kind of think now that there are lots of similarities in disease course between HD and other movement disorders that have motor and cognitive and behavioral symptoms. So the first one that comes to mind is something like Parkinson's disease, for example. So when you think about it, both HD and PD start out with non-motor symptoms, usually cognitive or behavioral. We call that stage prodromal. As the disease progresses, those non-motor symptoms increase, and then motor symptoms start to appear. And it's usually at the point that motor symptoms appear that we actually diagnose the disease. So in the case of Huntington's disease, it's usually the chorea. In the case of Parkinson's disease, it can be the tremor, okay? Now we know that the disease progression is inexorable, unfortunately. If there's no treatment, the disease just continues to progress. Obviously, if we had a cure at this point, the disease would stop, and that would be wonderful. And that's what we're really looking for. But I think it's important to also note that even a symptomatic treatment could have a great effect. So if we even initiate a symptomatic treatment, even after the point of diagnosis, we can actually see a significant difference in the slope from no treatment to symptomatic treatment. And so the symptoms themselves would be lessened in people. And what we expect is that there would be a later onset of the symptoms and a slower progression of those symptoms. So we talk about continuum of disease in Huntington's disease. And you can see that, I think, here. If you look at the y-axis, we're looking at function, signs and symptoms. If you look at this x-axis, we're looking at the clinical stages of Huntington's disease. So we talk about pre-manifest, which includes the pre-symptomatic stage and the prodromal stage, and then also manifest disease. So what's the difference? So everything prior to this diagnosis line is probably pre-manifest, and everything after diagnosis is considered manifest. In other words, it shows, we see the Huntington's disease. But the pre-manifest stage seems to have two stages, if you will. A pre-symptomatic stage in which, honestly, there are no symptoms whatsoever. And then a prodromal stage in which there may be some mild symptoms, maybe a little bit of cognitive difficulty, maybe a little bit of motor restlessness or something like that. And then finally, the motor symptoms appear, diagnosis is made, and people are considered manifest Huntington's disease. Of course, the motor impairment continues, the cognitive impairment continues, and unfortunately, functional abilities usually decline. And you see here, the typical adult onset, they have 45, but in fact, the age spans a very significant gamut. Now, when we talk about the clinical presentation of HD, we talk about a triad, and that triad is really motor symptoms and cognitive symptoms, and also what I would say psychiatric behavioral symptoms. The most common motor symptom is chorea, and that chorea has a very prominent effect on gait and coordination and speech and swallowing. And you guys all know that, probably better than I do. So, we talk about the most common motor symptom is chorea, but it's important to remember the gait and the coordination, the speech and the swallowing. Some people have tics, some people have dystonia, okay? Some people have abnormal eye movements, and all of this sort of starts to show up as the disease progresses. We also see cognitive changes, and mainly, at least initially, executive dysfunction, problems with problem solving, for example, maybe even more than memory, progressing though to full dementia, in which there are all kinds of cognitive problems. And then psychiatric and behavioral, oftentimes the most disturbing, depression, OCD or obsessive compulsive disorder, impulsivity, suicide risk, irritability, very common, sometimes personality changes, and a symptom that I was really struck by with a patient yesterday, apathy, because this was very difficult for the husband to comprehend, this apathy. And the first thing he told me was, she doesn't want to do anything. She just sits on the couch. She doesn't do anything. She's not motivated, Dr. Bloom, to do anything. She needs something to help her to do something. She needs to do things. And I tried to explain to him how apathy is so important in Huntington's disease and so debilitating in a lot of ways. I mean, I explained to him that there's just a lack of motivation, and it's not the person's fault. It's the fact that the frontal lobes, that part of the brain that we talked about before, the cortex, that frontal lobe, is not driving the basal ganglia to motivate the person. And so they can sit there, like he says, she sits there on the couch. Well, I explained to him, normally you sit down and, within about 5 seconds of whatever, you say, oh, I need to get up and put the wash on, or, oh, I need to get up and get that started for dinner, or, oh, I need to get up and, call so-and-so. I forgot I was supposed to call them by 4 o'clock today. But unfortunately, in Huntington's disease, and even pretty early in the course of the disease, that motivation factor starts to slip away. that becomes very difficult. And that's because the frontal lobes are not actively driving those basal ganglia and telling them to start thinking about all of those things that you need to get done and need to make sure get finished and completed and taken care of. And so oftentimes they do sit there, and he said, boy, all this time I was thinking she was just lazy. I said, no, not at all. This is the disease. This is organic. This is the disease. And you have to recognize that. And one of the hardest things for us is to really tell the difference between apathy and depression, because he was saying, oh, she's on 2 antidepressants. I thought maybe she needs a different antidepressant. It's not really depression. She still gets a lot of pleasure out of, people coming to see her and take her out and do things. She loves all of that, but she's not motivated herself to make the plans, to pick up the phone, to call someone to say, hey, let's go have lunch. Hey, why don't you come over here? Hey, let's do this or that, or to start the wash or start dinner or do those things. But if you come and get them, they will be fine and they will enjoy what they're doing. So he realized right away yesterday that he needs to set things up differently, because this apathy is what's really affecting her. He said, she's not cooking anymore. I said, no, she's probably not. I said, but if someone comes over and cooks with her, she probably will cook with them. So I think he began to really realize why it's so difficult and, for her, and what the early changes of apathy and the early personality changes can actually mean, to their lives. Okay, sorry. All right. So we do see a deterioration of brain functions in the clinical symptoms of HD. And as we said, cognitive symptoms can start really early, and some people feel now that they can occur up to 15 years before motor onset and deteriorate steadily. Also, behavioral symptoms, they can occur many years before diagnosis, but they can be more episodic. So people can see depression and maybe it's worse for some periods of time, or irritability and maybe it's worse for some periods of time. And the motor symptoms initially quite subtle, maybe a little restlessness or something like that, but really progress during the manifest stages with gait and balance problems and chorea and all of the motor difficulties that we know. In terms of depression, in terms of behavior, there's a couple of things I really like to point out. The apathy, as we talked about, depression, suicidal behavior, impaired judgment. Sometimes, people are so shocked or upset by, judgment decisions that are made, but that's actually part of it. So judgment, obsession and compulsive behavior, anxiety, sometimes even sleep disorders. With regard to cognition, it's not always memory. It actually can be communication difficulties, difficulty with what we call mental flexibility, using the information that people know to make a good decision or to make some good judgments. Cognitive slowing, and I think the slowing in general is something that becomes, quite obvious to people. And people slow down. They slow down cognitively, they slow down physically and motorically, and they begin to have lots of problems with planning. And then, of course, the motor things that we talked about, bradykinesia is slowing, chorea, rigidity, the speech and swallowing, the gait and balance disorders. Now, juvenile HD, I just try to remind people, is a little bit different. There, the onset is usually before 20 years of age. It's probably only about 5% of all cases of HD. The phenotype is actually different. There's much less chorea. We often don't see chorea at all in juvenile Huntington's disease, but there's much more Parkinsonism. People look much more rigid. They look much more dystonic. There's actually often more hallucinations and delusions, and they typically have very high numbers of CAG repeats, 55, 60, 65. We have patients with teenage onset or early adolescent onset with numbers of repeats 63, 65, 67. So very, very high numbers of repeat. So what kinds of therapies do we have available? There are 2 FDA-approved VMAT2 inhibitors, but this is mainly for the chorea, for the motor symptoms of HD. We have tetrabenazine and we have deutetrabenazine or Austedo. And there is another drug that I will tell you about shortly that is also a VMAT2 inhibitor that's being evaluated currently in clinical trials for the chorea of Huntington's disease. And honestly, these VMAT2 inhibitors are good. They work. They can help a lot with decreasing the chorea. Off-label, either we sometimes have to add some neuroleptics, drugs like flufenazine or risperidol, prolixin to help with the chorea, and they often can also help with psychosis. We also add antidepressants and mood stabilizers for the mood symptoms, but none of this has actually been evaluated specifically in Huntington's, which I think, is interesting. We don't have any proven therapies for cognition, but I'm excited to be able to tell you today about a new clinical trial that will be starting soon. And we don't have what I would consider to be disease-modifying therapy, or DMTs, disease-modifying therapy, something that actually can modify the course of disease, not just fix a little bit of the chorea or help with the cognitive symptoms. So I just want to remind people that the Austedo data was significant. It showed very significant differences between patients who were treated with the drug itself and also, who are on placebo. And so there was a difference of about 4 points, 4.4 points for patients who were treated with Austedo versus those who were on placebo. It, of course, went away right away as soon as the drug was stopped. And so that shows you it didn't modify the course of the disease at all. It's just a symptomatic therapy that helps while people are on the medicine. So it's not unlike a hypertensive medication, it's not unlike a hypertensive medication that works to lower high blood pressure, but if you come off of the medicine, it doesn't work any longer. And then just for you to realize that in the first study that looked at Austedo, the patients actually felt significantly improved. The global impression of change by the patient, this is the percent rating of much improved versus very much improved at week 12. And the patients felt that they were very much improved. And the clinicians actually also agreed that patients were very much improved. So I think clearly drugs like Austedo can make a difference, like all the VMAT2 inhibitors, to be honest with you. We tend to use Austedo a lot, but we also use tetrabenazine. And as I mentioned, there is another therapy that's being studied right now. So I think in general, those drugs can help with chorea. There's no doubt. What we need, though, are disease-modifying therapies. And the bulk of my discussion here today on investigative things will be on disease-modifying therapies. The first therapy is not a disease-modifying therapy, though. This is valbenazine, and this is for the treatment of chorea associated with Huntington's disease, like Austedo, like tetrabenazine. It is a vesicular monoamine transporter, or a VMAT2 inhibitor. This study is sponsored by Neurocrine Biosciences and also the Huntington Study Group. And the primary outcome measure is the change from baseline to maintenance in the UHDRS total maximal chorea score. So we're obviously looking to see whether or not there is an improvement in chorea. So if someone has a lot of chorea out there, or someone with a lot of chorea and they can't afford Austedo or tetrabenazine or don't feel like they've helped, you should call us, because the Connect HD study may be an option for you. Now, what about disease-modifying therapies? Well, that means that we want to go in and we want to alter the course of the disease. And the theory here is that if Huntington aggregates or clumps of Huntington are harmful to cells and kill the cells and cause loss of the cells in the brain, then maybe we can prevent all of the consequences of the HD mutation by lowering the amount of Huntington protein that accumulates. And what you see here in this cartoon is very simply the gene itself, the process of transcription by which the gene is transcribed to messenger RNA. And then that messenger RNA, boy, if I touch this, I sort of screw it up. That messenger RNA then is translated into the protein, in this case, the mutant Huntington protein, okay? And so this is a very common theme that we're going to see throughout all of the discussion on disease-modifying therapy. This is actually a normal process in the brain. We start with the gene for everything. The genes are transcribed into messenger RNA, and then to be made into protein, they have to be translated. So a very common phenomenon that occurs with all of our genes and all of the DNA in our makeup. The difference is that in this case, we're really focusing on HTT DNA, okay? And what I wanted to just show with this cartoon, from Lancet Neurology, is that there are a ton of scientific approaches now for disease-modifying therapy in HD. Many of them focus on the gene, some of them focus on the message, some of them focus on the protein itself. So that same process, if you will, okay? And so many of the approaches for disease-modifying therapy are looking at the HTT DNA itself. So we'll talk in a little bit about things like CRISPR or zinc finger proteins that are going to actually work at the level of DNA and affect transcription to mRNA, right? Okay. But there are other things. We've got antisense oligonucleotides. We have small molecules. We have RNAs. All of these are actually trying to affect the mRNA, okay, and prevent translation, all right, to the mutant Huntington protein. So really what we'd love to do is selectively allow translation of the good Huntington protein, the wild type Huntington protein, and selectively decrease translation of the mutant Huntington if we can. All right, so the strategies, not surprisingly, would be to reduce transcription by targeting DNA, and I already mentioned the CRISPR and the zinc finger, reduce translation by targeting mRNA, and we're going to talk about antisense oligonucleotides and small interfering RNAs. And again, always the plan or the hope is to decrease the making of the mutant Huntington protein. So I think all of you know about the Roche trial and also the WAVE trials. Those trials use antisense oligonucleotide. They ask those antisense oligonucleotides to selectively bind to the mRNA and result in its destruction so that less Huntington protein is made. And we know that, at least for the trials that we've had so far, that antisense drug had to be injected into patients via lumbar puncture or spinal tap. We would actually, put that medication, really, or that antisense oligonucleotide drug right into the cerebrospinal fluid so that it could go up around the brain, okay, and you can see it here circulating, all these areas in blue, circulating over the top of the brain right here, and then down into the foramen magnum area and the cisterns. And so all of it would circulate, and the hope is that in circulating, it would actually diffuse through the brain, okay, and then deep into the brain to the basal ganglia, where we needed to sort of make some improvement. Well, so there's a lot of things to think about. We're asking a lot, we're asking that stuff, if you will, that antisense oligonucleotide to come up from down here where it's being injected to actually diffuse not only into the brain, but deeply into the brain to the area of the basal ganglia. So one of the things we have to keep in mind is maybe we didn't get enough diffusion into the cortex, into the basal ganglia in the clinical trials that weren't so efficacious. So there's a lot of potential, I guess, and I'm sort of starting to bring it up now so we can start to think about where the problems may have occurred. I think most of you know, early on, several years ago, there was a phase 1b/2a study that enrolled 46 patients, and they gave this Roche compound, this antisense oligonucleotide, actually had been developed by ISIS, which then became Ionis Pharmaceuticals, but they gave that antisense oligonucleotide every 4 weeks for a total of 4 doses, so not very much, right? 4 doses, and they gave it to 46 patients, basically, and very excitingly, we saw that there was a dose-dependent lowering of mutant Huntington as a result. This is placebo, there's the mean amount. This is 10 milligrams, there's the mean lowering. 30 milligrams, a little bit more lowering. 60 milligrams, a little bit more lowering. 90 milligrams, even more lowering. It looks like it's sort of tapered off at about this point. And this is data from Sarah Tabrizi's article in New England Journal in 2019. But this was a lowering of mutant Huntington in the spinal fluid. This is the change, the percent change from baseline. And you can see that as the dose increased, there was a dose-dependent lowering of the mutant Huntington. And so we also thought that there was more lowering of the mutant Huntington even with time. And so we started the Degeneration HD study, which we enrolled 17 patients here at UCSD. There were 660 patients worldwide, 120 in the United States, with specific requirements. And there was placebo given every 8 weeks, drug given every 8 weeks, drug given every 16 weeks, with placebo every alternate 8 weeks. And the endpoints for this study were the composite UHDRS in Europe and the TFC, the total functional capacity, in the US. So 2 different endpoints depending on where the study was being done. Ultimately, there was there was also the open label trial, that patients were rolled into, and the anticipation was that there were going to be 950 patients in that open label continuation trial. So what went wrong? What happened? I think by now most of you know that dosing for the trial was halted. The trial itself is considered to be ongoing, but dosing has clearly been halted. And the DSMB recommended to stop the dosing, but to continue to follow the patients. And what they said at the time was that there were no new safety signals, but that there was a lack of efficacy. In reality, I think, the patients with the higher, more frequent dosing clearly showed worsening compared to the other patients. And so, I guess it is true that it wasn't a new safety signal. There weren't new things that, but clearly it was more than just the fact that patients didn't get better. They actually got worse. And so, I think there was a lot of concern, rightly so, by the DSMB at that point that they needed to stop dosing. And nobody really understands at this point, like what the issue was. So we need a lot more information. And I think we're just not in a position at this point to really comment very much, because the company themselves said they're not in a position to share the data because they don't want to share it in pieces. We really want to make sure that when we do share the data with the community, that we can give you as much of an explanation or description and understanding of what the data means as possible. So I think, there's so many questions. We need to know, like, what happened in terms of the lowering. Did the lowering of mutant Huntington happen the way we expected it to? Did it happen in the cortex? Did it happen deep in the brain, in the basal ganglia, the way we expected it to? Was the lowering too much in people who were getting high doses too frequently? Is it the fact that we didn't see it in the smaller number of patients with just a few doses? Does that suggest that maybe maybe people just needed a few doses and then much less in terms of dosing. I mean, these are all questions that are good questions, but we just don't know at this point. Is it possible that this compound worked for some people and not for others? Younger people versus older people, or people who were less advanced or more advanced than others? So these are, again, all questions that we don't know. So subgroup analyses are going to be very, very important. And as I mentioned, the dosing, was it too high? Was it too often? And, something to really think about: the higher the dose, the more often it's given. Maybe it lowered too much Huntington, and that includes the good stuff, the good Huntington, and maybe that sort of non-allele specific lowering had a negative effect. So we just don't really know, unfortunately, at this point. At the same time, or pretty simultaneously, unfortunately, a double hit, the WAVE Life Sciences trial also did not, looks like it bled over, sorry, did not, meet its endpoints. And so in this trial, the attempt was to actually lower only mutant Huntington and not all Huntington. So that's a very good focus. And the approach that they had enabled selective silencing, as I mentioned, of the disease-causing Huntington allele, but left the healthy Huntington allele to produce normal or wild type Huntington protein. Now, initially their plan was to target 2 of what they called SNPs. Sorry, I'm going back again. Let's see if I can, there we go. 2 SNPs. There was an 001 SNP and there was an 002 SNP. And the SNP2 is actually the trial that we did here in the US. SNP1 trial actually never got off the ground. And it's really the SNP2 trial that, is the only one that was actually done here. That trial has now been discontinued for lack of efficacy. But what we know there is that the Huntington lowering was not as much as they had expected. So we do have a good answer, in some ways there. So that was helpful. The very good news I can tell you is that, I'm going to move ahead on this, is that there is now a SNP3 trial underway. They've actually, WAVE already announced the initiation of dosing in that phase 1b/2a select HD clinical trial. And there they're looking at a different polymorphism, a SNP3 it is, that's commonly found on the expanded CAG allele. So this is also going to be an allele specific approach. So that's really good. We're hoping that it's only going to affect, as a result, the mutant Huntington, leaving the wild type Huntington to do what it needs to, and also protect patients more than, just indiscriminately lowering all of the Huntington. What other approaches do we have to lowering Huntington? Many. And so I think the exciting thing to really be able to say now is that beyond the ASOs, there are other things that we really are, pretty excited about. We're definitely excited about the ASOs, and we just need to learn what we need to learn about how to make them more efficacious and safer, for sure. But we're also looking at zinc finger proteins and small molecules and CRISPR Cas9, so that we can actually target the DNA, and then in some cases post-translational modification. So there are a lot of ways to actually do the same thing, and I'd like to explore some of them because there have been some really successful wins with regard to gene therapy. So gene therapy is quite different. It actually uses often a harmless virus, usually the adeno-associated virus. It can use AA5, it can use AA1, it can use AA9 to insert code for either a certain mRNA that's programmed to delete mutant RNA Huntington, and by this way, effectively reduce production of that mutant Huntington. The problem here is that it has to be injected directly into the basal ganglia, okay? So that is why we have to actually do brain surgery to accomplish this. So general anesthesia is required. We have to do burr holes drilled into the skull. We have to put catheters down into the brain and right into the basal ganglia. So these approaches actually target the basal ganglia themselves. They go into the caudate, they go into the putamen in order to deliver this therapy. And of course, they require a general anesthesia. The beauty of this approach is that after the 8 to 14 hour surgery is over, although invasive, it's kind of a one and done, you know, sort of a thing. So it would just be done one time. So what you see here are some cartoons to help explain the AMT 130 clinical program. And this is unicure's program. This is underway currently. It's actually halfway or slightly more to enrollment at this point. It does involve brain surgery. It does involve general anesthesia. They use 2 to 6 burr holes. They insert the catheters, and you can see right there, the catheter going into the brain. Okay, it's going to go down deep into the caudate. It's going to actually inject their product right there into the basal ganglia. And you can see this cartoon showing you the molecules sort of coming out and kind of being dispersed into the caudate. They call it an AMT 130 cocktail, which they inject. Patients are followed intensively for 18 months. They get lots of MRIs, they get LPs, and the patients who've actually been actively injected with the cocktail will then be followed annually for 5 years. So the difference here is that they are trying to permanently change the genetic makeup of that treated patient. They're not just trying to delete the HD mutation. So it's a big step. I believe that the people who are doing this are very, very brave. What you're seeing here is the adeno-associated viral vector itself. This is what we call the capsid, and it has this expression cassette in it. And it delivers that into the actual brain structures through those catheters. So as I said, uniQure has a randomized, double-blind, placebo-controlled safety and safety trial, primarily because it's an early phase 1b/2a. It's what we call a first-in-human trial, all right, because it hasn't been done before. So these people are really brave. It's multi-center, and in fact, it started in the US and has now moved to Europe. And it is a dose escalation study. So we started with 1 dose and they've now escalated to the higher dose. When the whole study is done, there will be 26 patients completed. These are patients with early manifest HD. They're aged 25 to 65. It's interesting because we call this an intrastriatal administration, and yet the patients who get the placebo, so 16 patients get the active drug, 10 patients get placebo. That surgery is really a sham surgery. They drill the burr holes, but they don't pierce the dura, so nothing goes deep in, but they do keep the patients under anesthesia for a similar amount of time so that nobody knows whether or not, you can't tell by the length of their procedure, for example, whether or not they got the real stuff or not. And because it's a safety trial, they're looking primarily at the number and type of adverse events that occur. But the Data Safety Monitoring Board is actually looking at really everything, quite honestly. And the good thing that I can tell you is that just recently, November 2nd of this year, they announced the fact that the Data Safety and Monitoring Board had no safety concerns in the first 4 patients enrolled in the higher dose cohort. So a total of 14 blinded administration procedures had been completed. That included people who got an active drug and people who'd gotten placebo, right? And so there's 12 patients. We said there were 26 total for the whole study. The final 12 patients in the second cohort, which is the higher dose cohort, have been cleared for enrollment. So this is really, very good news, I think, for this gene therapy approach. Now, when you have such an early phase study, a 1-2, this is really just a safety study. This is just to show whether it can be done and can it be done safely. And so, at least so far, with the first dose and now the higher dose, it seems to be, that we can do it safely, at least as far as the Data Safety and Monitoring Board is concerned. I will tell you that disappointingly, Voyager Therapeutics has suspended their gene therapy study that was due to start actually the end of this year. And we've been told, and I don't know, I don't know much more about it, but we've been told that they want to pursue something different rather than an intrastriatal injection. So we'll have to wait and see what happens there. Now, we said that if you're looking primarily at the DNA and not the RNA, you can also look at things like gene editing. And we mentioned 2 things earlier: zinc finger proteins, and also CRISPR Cas9. So we're going to talk about both of them. And what you see in that cartoon kind of on the left is zinc finger proteins, and I'll try to clarify that a little bit. Zinc finger proteins actually bind to the mutated Huntington gene. So they bind to the abnormal Huntington gene and try to block the actual abnormal Huntington gene from being transcribed into mRNA. And then, of course, with less mRNA, then they won't be translated into, protein. So if that makes sense, the zinc finger proteins are working at the DNA level, binding to the mutated Huntington DNA itself and blocking that Huntington DNA from being transcribed and therefore translated into mutant Huntington. CRISPR Cas9 is a little bit different, sorry. Oh boy, sorry. CRISPR Cas9 is a little bit different because there you get little single or double piece guide RNAs that introduce small mutations. Those little mutations attract Cas9 cleavage enzyme. So they attract a cleavage enzyme to cut the DNA strands at very targeted sites and prevent the reincorporation, therefore reducing the CAG repeat number itself. So rather than having 41 or 42 CAG repeats, the hope is that you can end up with 20 CAG repeats and therefore not make any more mutant Huntington, if that makes sense. So very, exciting approach. So let's kind of go back and look at these a little more carefully. Let's start with that those zinc finger drugs. So they stop the message from ever getting made in the first place. And what you can see here is the level of the DNA. All right, and so they block the HD gene, the mutant gene at its source. All right, and so basically, what we know is that when zinc itself hooks up with a gene controlling protein, it forms a zinc finger protein, and that zinc finger protein is what sticks to the long stretches of the HD gene, the harmfully long stretches, right? The abnormal, the mutant portion, and tells the cells not to read the gene. So unlike the antisense oligonucleotides and the small interfering RNAs that target RNA, zinc finger proteins target DNA and actually the mutant DNA itself. So that's a very exciting, approach. And why are they called zinc finger proteins? Well, they're actually transcription factors But if you look at them up here, one of the scientists who was looking at them said, hey, you know, they kind of look like fingers, I think. I'm going to call those finger, you know, proteins. And then because zinc binds to them, they called them zinc finger proteins. So these are transcription factors. They're inhibitory transcription factors. Let's see, sorry. Okay, so gene editing and gene editing using CRISPR Cas9 is another highly technical approach, but people are pretty excited about it. And with this approach, you try to edit the DNA itself to just remove the mutation altogether. And if we look at this little cartoon right here, you see some scissors, and they're cutting kind of at this point right here. So this tells you that you are in the abnormal gene, the mutant Huntington gene part of things, right? And so what ends up happening is this caspase-9, which is really an enzyme, comes in to cut the DNA itself at this specific target sequence, and it gets rid of all the excess CAG repeats as a result. So the guide RNA finds the exact right spot on the DNA, okay? And then the caspase-9, which is an enzyme, actually comes in and cuts the DNA at this point. And in the end, we're hoping that rather than having 41 or 42 CAG repeats right there, you'll end up with something more like 18, 19, 20, something like that. That's much more normal. And so as a result, you won't make any more of the mutant Huntington. Now, unfortunately, it's not yet ready for humans, and it's been looked at in mice and in fruit flies. And I think there's even some avian work, like chickens or something, you know, to date. But I would say it's clearly moving along and very, very exciting. And most people feel that delivering the CRISPR Cas9 technology is likely going to be the biggest limitation. So what do we take home from all of this? We take home from all of this the fact that people are really working hard on disease-modifying therapy, and that disease-modifying therapy is inching ever closer to reality. So the antisense oligonucleotide therapies, you know, are the first ones that have kind of gone into studies, gone into human trials. And of course, now we see with some setbacks, it's still very possible that they may reemerge, maybe changed with regard to dosing or timing or delivery or all those kinds of things. And they may then slow the rate of progression, but will likely require ongoing therapy. A lot of people feel that if we continue to try and deliver the therapy intrathecally or by lumbar puncture, that we may only see cortically predominant effects, that it may be too difficult for the therapy to diffuse deep into the brain to the basal ganglia. We may actually have to find some selectivity, all right? So in other words, maybe we don't want to get rid of all the good stuff too, the good Huntington protein. So selectivity refers to just being able to get rid of the mutant Huntington. And that would probably, I mean, the feeling is that would probably result in a better effect. And whether or not these could still be virtual cures, especially if we started in a pre-symptomatic phase, we really don't know. But I think, you know, we're still many ways away from seeing the end of antisense oligonucleotide therapies. Gene therapies are actually having some promising results, at least in terms of delivery and safety, okay? But they're clearly much more invasive, and we obviously know nothing about efficacy, whether they accomplished anything at this point. But it's still pretty exciting to realize that they've been done, and they've been done safely. And then, of course, the gene editing therapies are pretty fascinating, but still in preclinical phases in mice and fruit flies and chickens. Okay, so what are we currently doing here? What do we have going on in San Diego? What's currently enrolling? What's ongoing? What can you get into? We have a lot of stuff, actually. I'm going to talk about Enroll HD because if people are not in Enroll, I beg you or your family members to get into it. It really is the way that patients are selected for clinical trials. And it's a really, really important registry program that we, are really excited about and, feel good about our center. We're actually the second largest enroll site in the US, and we're pretty proud of it, but it's really important to bring people back. And one of the problems I think that we're really running into is we've enrolled a lot of people, but it's really tough to actually get people to come back the next year and the next year and the next year, even though they get a $75 gift card. But we really need you to come back because we get dinged if you don't come back. And it really is important for us to be able to follow the natural history of HD. So we do ask you, please answer your phones. I know we leave messages and emails, and I know people tell me that sometimes there's nobody responds. So if you really are involved in Enroll and hear from any of these guys, please answer them. And then we have Shield HD, which is already enrolled and ongoing, but it is going to be followed by a clinical trial. This is pretty exciting. I told you the wave that was Precision HD 1 and 2 are on hold, but we don't have Precision HD 3 because it's only being done in Canada and Europe at this point. Generation HD 1, that's actually the Roche study that is enrolled, but as you know, has been halted. Connect HD is enrolling, and I'll tell you all about that. Proof HD is enrolled and ongoing, and that's, we're not enrolling any more people in that right now. But we're about to begin 2 new studies, a SAGE study, and also PTC Therapeutics is called Pivot HD that we will be starting. So let me briefly just tell you about Enroll. This is really pretty exciting. There's 182 active sites in the world in 22 countries. This is an opportunity to be a part of a huge registry program. And I think really, really exciting. And what they're trying to do, CHDI, is really make this a very, very significant platform for HD research. Let's see if we can get this to go. We have 20,794 active participants as of November 1st of this year. There are 30,000 plus baseline and follow-up visits. As I said, it's actually, sorry, I don't know why it's coming back. It's actually good for subjects and it's actually good for research because a lot of the sites for clinical trials are picked based on the number of enrolled subjects. So if you're interested, if you have family members, if you've enrolled, but you've got brothers or sisters or family members who haven't enrolled, please call Haley at 858-249-0569. She would love to hear from you. We have the Shield HD program. As I mentioned, this is sponsored by Triplet Therapeutics. This is a natural history study to look at increased gene expansion carriers. We call them HDGECs. This is an international prospective longitudinal cohort study. They want to look at the natural history of HD and its biomarkers associated with modulating CAG repeats in mutant Huntingtons. Only 70 patients could participate. I think we enrolled something like 13 or 15, so we're pretty excited about that. There's a 24-month follow-up. It was North America and Europe. And what they're looking at is something called DNA damage repair gene expression, DNA damage repair. And they're looking at it in accessible biofluids like serum and spinal fluid. And they're establishing disease trajectories for their established and novel biomarkers and clinical outcomes. And the interesting thing about these DDR proteins, they think that these DDR proteins drive repeat expansion. So in other words, there's a reason why the normal number of 18 or 19 or 20 CAG repeats increase in HD, okay, and go to 38, 39, 40, 41, 42, 43. And they feel that it's driven by these DDR proteins, okay? So they would like to target some of the specific DDR proteins with antisense oligonucleotides and small interfering RNAs to stop that repeat expansion. So we think this is really exciting. And so all of those people who did enroll in this SHIELD HD registry study will be able to participate in the clinical trial when it comes about, which should be in another year. We may end up also recruiting from the enroll registry. And then Prolenia, many of you have enrolled in Proof HD. This is a phase 3 clinical trial for Huntington's disease in the US. I'm proud to tell you that Proof HD is completely enrolled now. So it is done. It's a study being done with Prolenia and with the Huntington study group. It is a highly selective sigma-1 receptor agonist that's expressed at very high levels in the brain. And the thought is that it regulates a lot of key cellular pathways that are commonly impaired in neurodegeneration. Patients themselves are taking the medication twice a day. There are 60 study centers in the US, Canada, and Europe, and the treatment period is going to last up to 78 weeks with an optional open label extension. So that is underway, and we're looking for results there. Enrolling soon is a very interesting study, something that's warm and close to my heart because of my interest in cognition. And this is a study sponsored by Sage Therapeutics. This is a study, a randomized placebo-controlled double-blind study to evaluate the effect of Sage 718 on cognitive function in participants with Huntington's disease. This is a very interesting compound. It's actually related in some ways to the drug memantine, which is given in Alzheimer's disease. It's a novel oxysterol-based NMDA receptor modulator. And the thought is that it's able to restore NMDA receptor tone and get rid of some of the cognitive deficits in Huntington's disease. And I am told there will also be another study by Sage that they've asked us to consider participating in. We just need to see if we have room. But this is going to be a functional study. So it's going to be the same molecule, but they're going to be looking at function in Huntington's disease, and particularly driving. So there will be a driving simulator as part of this study. You can see this, or that study. You can see the study design right here. It's not a very long trial. And so if people are interested, please let us know. There is a screening period. There's a 12-week treatment period, and then a follow-up period. So we think we should know pretty quickly whether or not there is a benefit from this medication on cognition. We're also going to be enrolling soon for something called Pivot HD. This is sponsored by PTC Therapeutics. They have a program of small molecule drugs and gene therapy, hoping to regulate gene expression by targeting post-transcriptional control mechanisms. The cool thing about this is that it's orally bioavailable. So it penetrates the blood-brain barrier after taking it orally. Yay! That's great. And we think that there's even very even penetration of the brain and even all of the other tissues in the body. And at least in the mouse models that had expanded Huntington transgenes, it was effective in decreasing Huntington protein. So this is also a very exciting attempt to lower Huntington using an oral medication. And you may think, wow, how's that going to work? Well, this shows you some of their data. This is from mice, and they're looking at lowering HTT protein in whole blood and also brain. So here you see whole blood, here you see brain. So this is when the medicine isn't given. That's the Huntington protein level. And then here it's actually being expressed as a % of the baseline Huntington protein. But here is what you see in patients treated with PTC 518. And this is in the brain, vehicle, and then treatment with PTC. So you have pretty significant lowering. In this case, in the brain, it's about 50% lowering of Huntington protein. And in this case, in the blood, it's about a 45%, something like that, lowering. We do think that there's dose-dependent lowering. So the higher the dose, the greater the lowering. Here we see the most lowering. And then demonstrated uniform HTT lowering across brain regions. So here they're looking at the striatum, the cortex, and the cerebellum. Okay, so all in the sort of 40 to 50, 55% lowering range. So pretty excited about this study. This is going to be a phase 2A randomized placebo-controlled parallel arm dose ranging study. We will be starting this soon. It will be occurring in Australia, Canada, France, Germany, Netherlands, UK, and the USA. There's going to be about 20 sites. We have been selected as a site, so we're pretty excited about that. There will be 105 randomized subjects only, and it is competitive. So the faster we get them in and faster we get people enrolled, the more slots we can take. So they're not like preserving slots for each site so that everybody gets the same amount. So they just, I guess they reward the people who get more patients in. Okay. And so I think with that, I'm going to say, you guys hope you're not sleeping out there, but thanks for your attention. You've been a really, really great audience. And I hope you feel as excited as I am, you know, about the current state of HD research and the future. So with that, I will take some questions.
Question, Dr. Bloom.
Can you see me now? There I am. Okay.
Can you hear me?
Yes, I hear someone.
Okay. Hi, this is Jennifer Hill.
Oh, hi, Jennifer. How are you?
Good. How are you?
Good.
I need to come in to get my enroll done for
Yes,
this.
please, please.
I'm
Okay,
coming.
you guys write it down. Jennifer said so.
Yeah, I did. I just messaged Haley.
Good job.
Yeah, so my question because I'm pre-symptomatic and positive, are there any other studies besides enroll that I can join?
So not right now, to be honest with you, but it won't be long, because I think what we're seeing is that people are definitely trying to move things back a little bit. I will make sure, because most of the studies that we have require formulations and calculations. And so sometimes people surprise us and they're okay for a study because of their CAG repeat, their age, you know, just sort of different factors. So we have to use all of that and compute it. So I'll ask actually Haley and Chase to, you know, see whether or not you can actually be okay for any of the trials that we're enrolling.
Yeah, if I qualify, because I don't have
Yeah.
symptoms yet. So yeah, just ask
Yeah.
them and let me know.
Thank you. I appreciate it.
Thank you.
Dr. Bloom, someone had a question. The question was, do all the enrolling studies have an age 65 cutoff?
Do all the, so I didn't know that, actually. I'm not sure I remember that. Is Haley or Chase, are you on 65 cutoff for enroll?
Oh, no, I think he was asking if all of the clinical trials have an age cutoff at 65.
Oh, okay, yeah, because I was like sitting there thinking, yeah, I don't think enroll has it. Yeah, but I wanted to make sure, because I'm never right on everything. No, they don't. Actually, they don't. And so it's really important to actually check. We really fight hard when they say 65. So all of the studies don't. And so, you know, we have somebody who's 80 that wanted to participate in a clinical trial, and they said no for that. It was 80. But, you know, generally speaking, it's really trial by trial. 65 is common in a lot of them, but not every single trial. So it's always worth asking or looking. Thank you for that.
Who's monitoring this, or
I am.
what? Who's answering the questions? I mean, who lets somebody on to ask a question?
You can,
Go ahead.
there's,
Just unmute yourself. Ask away.
Oh, okay.
do you want to ask a question?
No, I don't.
Okay,
I
well,
just was
Oh.
curious.
Yeah, if anyone has any questions, go ahead and unmute yourself right now and go ahead and ask the question.
Hi, Dr. Corey Bloom and Doug. This is Ken, or Gene Veritas, the blogger. And I wanted to know, I have a lot, but I wanted to start with just one, and I
Okay.
don't want to take time up from other people, so I'll just let other. But one question I had is, you, Dr. Corey Bloom, you talked about the triplet study.
Right.
And that they originally said that they hope to start their phase 1 this year.
I know.
Can you tell us why it's been their planning has been delayed? And also, could you comment on the fact that they want to use I think, what is it called, intraventricular injection? They want to put like a little like a reservoir on top of the head.
Right.
Inject the drug that way, and then
Right.
that'll be what, a permanent way of getting in and out of the brain.
Right.
If you could just talk a little
Sure.
bit about that.
Sure. So I
How
have
that-
no idea. Yeah. So Ken, I
Oh.
honestly have no idea why it's delayed. We've been asking ourselves the same. We've been, let me put it this way. We've been realizing that they haven't started to tell us about the trial. And, usually it takes 6 to 8 months to kind of get something going. So if you think you're going to get something going at a certain time, 6 or 8 months before, you have to at least be hearing about it and getting regulatory stuff and thinking about it. So we think it's going to be delayed. And what I asked, actually the monitor who came, I asked, does anybody have any idea how long? And does anybody know, are we going to continue the natural history study until it starts? And so I had all the same questions probably that you have. So we haven't heard anything yet, but as soon as we hear anything, we will let you know. So this, to be honest with you, what you're describing is the Ommaya reservoir. And I wanted Roche actually to use an Ommaya reservoir. When I was a resident, we used to give chemotherapy intraventricularly and into the spinal column by using an Ommaya reservoir. And so what they do is, it's so easy. It's like a little bleb about the size of a dime or a nickel, something like that. It's a firm plastic, but you can stick a needle through it, which is really nice. And it's implanted under the scalp. Okay, we implanted them actually in the neck for many people because we wanted to go into the basilar cisterns. But the beauty of it is the other end of it goes into the ventricle. So it goes right into the ventricle. And why that's better is there you are closer to the basal ganglia, which is what you want to be near, number one. And so you've got this tubing that's going right into the ventricle, which is fantastic. And then you've got this little bleb that's right under the scalp. Well, what's gorgeous about that is that you can just feel it, clean it, and stick your needle in and pull out all the spinal fluid that you want, or put in all the medicine that you want. No more lumbar punctures, no more spinal taps, none of it, it's all gone. So I couldn't understand, really, I kept saying to the guys at Roche, why aren't you using Ommaya reservoirs? It makes no sense. And I think they just didn't really, well, they started down the LP route, and also the SMA studies had been done that way and blah, blah, blah. And so, rightly so, they recognized that if they were going to give the medicine by an Ommaya, which is close up here near the brain versus way down here, the dose wouldn't be the same. So they said, we can't use our dose finding stuff, so they didn't want to start over. They didn't want, but I kept saying to them, I said, why don't you just add another arm while you're, just add another arm, keep everything the same, keep it going, and add some sort of other arm that sort of just gives it by Ommaya. So at least you have a small number of people that you can see what happens with one. Anyway, they didn't. So I'm actually kind of glad that triplet is going the route of Ommaya, because honestly, even though the LPs have really gone well, and oh my God, I cannot believe how wonderful all the patients have been in terms of coming back for them, but we have two really good LPers, so not me. So that's why it's good, Dr. Wright and Chris Nissen. And so, the beauty is that, people, have, it's gone so well that people have come back and they've gotten lots of LPs generally. But if somebody has to do it for life, I'm not sure they're going to want to do an LP for life. So I think the Omaya is just so much better. It doesn't, it doesn't affect your appearance at all. Nobody can tell. It's underneath the scalp. It's kind of either, I don't know exactly where they're going to want the placement, but it's underneath the scalp and it's just really easy to get to. You can feel it. It's just a little prominence and boom, clean it, stick it in, boom. And so, I think it's a great idea. I'm glad they're doing it. I assume it's probably, thinking about what could be delaying triplet, they've got to get all their dose finding studies in animals. They've got to decide on humans. They've got to then translate maybe what they had initially decided to do in animals now to maybe an Omaya reservoir. I'm sure that it's all kinds of stuff like that. But I think we should probably ask, what's her name? Irina. Ken, you would be the person to call her up and ask her.
I'll follow up when I get a chance, definitely.
Yeah, because it's a great question. And I think, I think coming from you, she's going to have to come up with some kind of answer.
Right, yeah.
Right.
Well, thank you for pushing.
Sure.
I know you've talked for years about the Omaya thing.
I know.
Yeah,
I know.
so thank you
so
for
funny.
pushing on that.
Yeah, no, I agree.
Your influence is being felt.
Thank you. So does everyone feel hopeful? Do people feel hopeful about the future? Do they feel good? They feel like there are some options out there and things are happening or no?
I do.
Yeah.
Most certainly.
Hi,
Dr.
Rajiv. Hello.
I have a question for you.
Sure.
It is a more general question. And
Uh-huh.
I'm thinking in terms of DNA interventions, the recent with respect to COVID for DNA, RNA, and things like that. Is that going to be helpful in approach, similar CRISPR approach for HD?
It's a good question. It's a really good question. I don't know. I can imagine because I think, already I heard that all of this is going to now help with, different treatments, COVID treatments, everything, different treatments for neurodegenerative diseases. Some people were mentioning MS, as a result, and so, given, the immune system and the technology that COVID vaccination has generated, they're already saying that there may be therapies for MS that will come out of COVID vaccinations. Now that's multiple sclerosis. So, all of the, whether or not it actually, brings, whether they focus their attention on neurodegenerative things right now, I don't know. So it's going to take some of those amazingly smart scientists to sort of do that. But I suspect yes. I definitely suspect yes.
All right, but by the way, you did mention CRISPR.
Yes.
And how's that tied with the recent research they had for COVID?
The CRISPR, yeah. I don't know exactly whether it's, you mean whether it's going to have an impact on HD or, yeah.
You did
Yeah.
mention CRISPR intervention also for HD, isn't it?
Yeah. Yeah. I don't know, but it's a very good question. And I think it's possible. It's going to, right now what they're saying is that the delivery is difficult and they're also a little concerned about harnessing it. As you can imagine, if you start enzymes cutting DNA, you better make sure that you've got a stopping mechanism, because if it starts to go haywire, so I feel like we make it sound easy. And I think probably like in a mouse or in bacteria, which is where it started, it's probably easy to control it, but I'm not so sure in a human it's so easy to concern it.
I didn't realize the difference.
Yeah.
I didn't realize the difference.
Yeah. Yeah.
I thought humans are also bacterial.
Yes. I like it. We definitely are.
All right, thank you very much. Nice seeing
Thank you. Thank you.
Dr.
So-
Oberlin, I
Yes?
have one other question.
Please.
This is Julie.
I know, I can see you, Julie.
My nephew was in the Roche study
Okay.
and they took him off of it, obviously. How long are they going to be examining him, you think, from now on?
Yeah, I mean, it's a really good question. I mean, I think that, if you believe that, so, I don't know. I'm going to just say, I don't know. But if you
Right.
believe that maybe too much of the medication was given,
Right.
Then
Right.
what you really want to do is see people along the way as the amount decreases, because if you
Right.
stop giving them, we should start to see a decrease. Now, maybe there will become a sweet spot that we will recognize and say, this was a better spot. This was a better, we don't
Right.
lower mutant Huntington, or we lowered mutant Huntington. We didn't lower any wild type or good Huntington at all at this dosing, or very little of it. So I think that's why the company is really asking for everyone to stick with it and to please continue to do the LPs, because they want to look and see if they can actually find a point at which it makes more sense. It's so, you just never know when you do a short trial like they did initially, and you look at 4 or 5 doses and you say, wow, this is great. It's lowering it. You don't know, like, when you get to that kind of toxic state, right? I mean, so we were giving it every 8 weeks and every 4 weeks, and then they changed it to 16 and 8. And what was really kind of interesting about that was that I guess the people who were getting it less often actually did better ultimately than the people who were getting it, more frequently. So now I haven't seen a publication, but this is kind of all the little stuff that we hear, kind of through the grapevine. That I did hear that we did hear a little presentation at HSG this year. So it's just a week ago, from Scott Schobel, who actually won't be with the Huntington program anymore. For those of you who remember him, Scott Schobel, he was the sort of big director of the Huntington trial. He won't be with them anymore. He is actually moving to Alzheimer's disease. But they did introduce the new guy who, I don't know his name, I can't remember his name, but he will be taking it over and working on it. And they did say that they thought that they would have maybe by January, February, some more information. So that was pretty exciting to me, because I mean, they have thousands and thousands and thousands and thousands of samples that they have to kind of go through. And so what I think they have so much to look at, like body size and just drug levels, like in CSF, in plasma, performance, were there correlations, was there not, was there a point at which that people did well for a while and then maybe they started to turn sour? If that's true, that would be really helpful to find that inflection point and then back up and look at the dosing. So I mean, I just think there's so much. So they said they thought they would be able to give some more information come January, February. I don't know if that's true. But if that is true, that would be exciting. And the CHDI meeting that takes place in Palm Springs is usually the last week of February every year. So I was thinking to myself, oh, that would be a good time to sort of come out with it.
Jody, this is Michael Piersbacher.
Hi.
Hi, I ran across a company on LinkedIn, Locana Bio,
Oh,
that has an HD program.
yeah,
You know-
I just heard of them, actually. Somebody else just mentioned them to me. Yeah. What do
It
you
was-
know about
It was of
them?
our walk.
I couldn't tell much from the website, and I was wondering if you knew any more about them than I do.
No, I wrote it down, though. I've got to tell you, I know that they have raised quite a bit of money. I know that they are looking at precision medicines, and that's right. Didn't they sponsor the walk?
Yeah.
Yeah, and they said that they're targeting RNA. And that was something I had just kind of looked them up. But maybe we should invite them to like come and talk about their technology or something. What do you guys think?
Absolutely.
Yeah, they're very private. Sometimes you can get them, especially for a patient group. Sometimes you can. They're very private, though, sometimes about their proprietary stuff, like what exactly they're doing. They give you this kind of blurb, but it doesn't really tell you really. I know we haven't been approached by them, at all for a clinical trial. So I don't think that they are that far along. They say that they correct dysfunctional messenger RNA. And I remember going and looking after somebody mentioned them to me. I thought that I would look at their leadership team to see if I knew anybody, and I don't. So that was kind of interesting. Now, this guy, Ron Batra, I do know because he contacted me to learn about HD and wanted to come to clinic. And I ended up having to tell him, unfortunately, because he's not an MD, it's really hard for us to get, you can imagine with confidentiality and everything, it's really hard for us to get a permission, especially with HD, for outside people to just come. He wanted to come to clinic and see some HD patients. And so, it wasn't right. And so, I kind of said, wow, unfortunately, I really can't do that. And then I didn't hear anything from him, so I thought, oh, okay, well, whatever. But I know one other person, and that's this guy, Gene Yeo, Y-E-O. And he is a co-founder and scientific advisor for this company. And Gene is actually a professor here at UCSD. And he's unbelievably smart, a molecular biologist. So I'm kind of wondering, what I understood from this Ron Batra was that they're kind of in too early stages at this point to start talking about a clinical trial. They're not there yet. But I'm just kind of wondering if maybe we could get them to come and do, some kind of a talk to a support group or something about their technology and what they do. I don't think they'll be as defensive about going in front of, scientists or docs or something. But I think for patients, we could probably glean, and because we're all smart patients, we could probably glean like a lot of good information from them about what they're doing and where they are. Because I couldn't actually get a good idea about where they were in their kind of growth. I didn't have the sense they were ready to start a trial, no. But they sound interesting for sure. So maybe, Doug, maybe you guys can get them to come for a support group.
Well, we actually contacted them to do in-person support group in one of their buildings, but I think the liability is too much of an issue.
Okay.
But I'll talk to
So
the
maybe
other-
they'll do a virtual. Maybe they'll do a virtual.
Yeah.
Yeah.
We'll definitely look into it.
I applied for a job there.
Oh,
So if I get an interview, I'll mention
then
it.
you'll really know, right? Thanks, Michael.
Right.
That's great. Yeah, this guy, this Ron Batra seems to do pretty much everything. He is a PhD. And they have a chief medical officer too. I don't know who that guy is. So yeah, I don't know. It's I'd love to hear a little bit more about them. They all play everything very close to their chest though, especially when they're looking for funding. They don't want anyone to know anything. Right? Do I lie? Michael, do I lie? No.
No. This is absolutely true.
Yeah, it's absolutely true. So at any rate, but I would love to hear it. Well, if you guys don't have any more questions, I am going to feed my husband lunch today. What do you think about
Leah,
that?
one more question.
Sure, please.
Any info on treatment for apathy and sleep disorder exhaustion?
Yeah, very good question. That is a really, really good question. We have nothing good for apathy. We have absolutely nothing good for apathy. It's such a strange, it is, we treat it with antidepressants, but it's not depression, they need something that drives them. And I was often thinking, I wonder if a dopamine drug would actually be helpful to kind of drive the basal ganglia a little bit. So I have been thinking about that. Believe it or not, I have been thinking about doing our own study to look at apathy. There are a few apathy scales out there. So we have to have scales to measure an improvement. But I don't think it's depression. I believe that it is just a lack of driving that, that frontal cortex not driving the basal ganglia. So if anybody has a good idea, please let me know. Sleep, most of the people, I mean, we obviously use trazodone and we use Remeron, especially for HD, because it also increases weight a little bit, it's sedating. And then in the Parkinson's field, they tend to love melatonin. So we've been adding some melatonin, but we don't have really great sleepers either there. Sometimes people take Klonopin if movements are a problem, kicking, that kind of thing. But yeah, I would say a good sleep study would be great too. So both good ideas, Doug.
Well, thank you very much, Dr. Bloom.
Thank you guys. Stay well. Okay, have
Yeah.
wonderful Thanksgiving. Take care of your families and take care of each other.
Thank you
Okay.
for the info.
Yeah. Yeah. Bye. Take care.
Thank you,
Thank
Dr. Bloom.
Bye-bye.
Thank you.
Thank you.
Give your husband a hug from us.
I will every day.
Yeah.